Stuart is a working clinician, so he's the ideal person to update us on Romosozumab, because I think he does have quite a bit of personal experience in its use. So Stuart, thank you very much for taking the time to speak to us today, and we're all waiting with bated breath to hear from you.
Okay, thanks Alison, thanks Maureen. I'm gonna wait for the weekend, so I'm gonna shoot off for the round robin, just to say we've got a massive backlog, but we're getting through it. But Monica and Tracy, I think, are here, who will be able to give you more details. Okay, so I'm just going to share my screen. Blah, blah, blah. Here we go. And right, can you see that all? Yes?
Yes, we can.
Thanks.
Yep.
Okay, so Romosozumab, why, when, and who, or in whom? So we've got a lot of drug treatments now for osteoporosis listed here, but Romo, as I'm going to call it, is the newest one, and probably one of the most exciting ones, I have to say. It's a novel anabolic agent. The only real anabolic agent we've got is teriparatide, or we had is teriparatide, and Romo is another one added to that list. This was the first paper, or the first, it was a phase 3 trial of Romosozumab placebo-controlled by Felicia Cosman. I think it was 2018 anyway. That was the first trial. But just to appraise you on how Romosozumab works, well, basically, Romosozumab is a monoclonal antibody, or MAB, and it inhibits a molecule called sclerostin, or SOSN. Now, sclerostin is made by osteocytes, and the function of sclerostin is actually to inhibit bone formation, and it also stimulates bone resorption a little. So the way Romo works is it inhibits the inhibitor, if you like, and because of that, it has quite a profound anabolic effect. I'm showing data here from the Cosman study, so it was 2016, gosh, that long ago, which looks at biochemical markers in the Romosozumab study. It's a subgroup of it, not the whole population. And so what you're looking at in the left-hand panel of the slide is P1NP, that's a marker of bone formation, that's the blue, and CTX, which is a marker of bone resorption, that is the red. Now, unlike any other drug we know of, Romo stimulates bone formation, quite a decent increase, about 150% at 4 weeks or so, but then, and it remains up, but even though you keep going with Romo, gradually it fades off, and by a year, you're back down to baseline. And in fact, this is why we only give it for a year, because you can keep going with Romo for years and years and years, but you don't get any more of an anabolic effect. I'm not sure quite that is, whether it's downregulation of receptors, but anyway, there you go. So accompanying the increase in bone formation, you have a decrease in bone resorption. That's the orange line. That's not so profound as, for example, with the likes of alendronate or zoledronic acid. But when you combine a stimulation of bone formation with an inhibition of bone resorption, that gives you a pretty useful drug. And after 12 months in the Cosman trial, as shown here on the slide, there was a 13.6 increase in spine BMD, which is really astonishing. That's in 1 year, so that's probably more than you might get with teriparatide over 2 years. And also more importantly, or equally important, is you get, or in this study, there was a 6.8% increase in hip BMD. And again, that's something you don't get with teriparatide. Now, the key study with Romosozumab is this one. And it was a brave study for UCB to do, because it was a head-to-head with what is really the standard of care. And they compared Romosozumab with alendronate in women with osteoporosis. We were a centre in this study. We took part on it. And these women had severe osteoporosis. Most of them, nearly all of them, had vertebral fractures. And those were the two groups. And this summarises the results of the ARCH study, as it's so called. And the results are just extremely impressive. So the fractures in the alendronate group are red, or bars are red. The fractures in the Romo group are blue. And remember that alendronate is a good treatment for osteoporosis, but compared with alendronate, Romosozumab halved the vertebral fractures, gave maybe about a 15-20% reduction in non-vert, about a little bit more, I think it was about 30% reduction in hip, and any fracture about 25%. So really very impressive. So it's probably the best treatment, or at least the most effective treatment we have. Now, it's not yet been viewed by NICE, or not yet been reviewed by NICE, but it has been reviewed by the SMC. And as Alison said, I chaired the SIGN 142 guideline. We looked at it before SIGN had looked at it, and we were well impressed, and we wanted to recommend it. But the rule is with SIGN is you can't recommend something if it's not been looked at by SMC. Anyway, luckily SMC accepted it for restrictive use. The indication was severe osteoporosis in postmenopausal women at high risk of fracture. And then they said it's for use in patients who experience a fragility fracture, so you've got to previously had a fracture, who are at imminent risk of another fragility fracture. So if we look at SIGN 142, which was very much evidence-based, this is the recommendation from 6.4.9 of the guidance. So it's recommended for postmenopausal women with severe osteoporosis who have experienced a fragility fracture, so that's okay, to reduce the risk of vertebral, non-vertebral, and hip fractures. The important thing is that we reckon that it was best used, or at least in postmenopausal women with one severe or two moderate low trauma vert fracs, it was recommended over oral bisphosphonates to prevent further fractures. So in SIGN, we thought we should be placing it in the severe spinal osteoporosis category, really as first line, and that came from the ARC study. And then the final part of the recommendation was that once you've stopped it, like other anabolics, you should probably start an anti-resorptive agent. So this diagram just really summarizes where we think, or at least SIGN thinks, romosozumab should be placed. It's certainly where I think romosozumab should be placed. And so I've just copied a little bit of the SIGN algorithm. So you can get down to this severe osteoporosis of the spine. So that's osteoporosis with at least two vertebral fractures or one severe vertebral fracture. If the answer to that is no, then you're probably going down the alendronate or risedronate road. If you do have severe osteoporosis of the spine and you've got high risk of a further fracture, and nearly all of these patients will be, you're talking about an anabolic drug. And you can either have romosozumab or teriparatide, and both of those are valid choices. And then with both of them, you're looking to transition to anti-resorptive treatment. So I thought, as Alison has said, we've treated quite a few patients now in Lothian. I think we're 17 or 19. And I thought I'd share a couple of case histories. Here's one. It's one of the early patients we treated. A 73-year-old woman. She slipped while walking down the stairs and kind of fell on her back. Very severe back pain. She hadn't had much in the way of previous fractures. She'd fractured her sternum, but only after falling from a bike in 2017. And otherwise, her medical history wasn't very remarkable. She wasn't severely injured after this fall, no neuroscience. Her mid-thoracic spine was tender, and she had some bloods checked and spine x-ray performed. And I'm just showing those, and what you can see is she's got pretty severe vertebral fractures of T6, T8, T9, and 11. Routine bloods were unremarkable, and vitamin D wasn't bad for someone in Scotland, but her DEXA showed quite severe osteoporosis. So the spine T-score was minus 3.7, total hip minus 3.0. And if you looked at her major osteoporotic fracture risk, it was 23%. So that's definitely in the treatment range. And we discussed the pros and cons with her, and said, well, you could have alendronate, but Romo is probably going to be better. Because of the kind of quite high, the low hip T-score and the high risk of hip fracture, we thought that Romo would be more suitable than teriparatide, and she was started on it in February, and she's managing it quite well. So that's one. It's that kind of patient we're using romosozumab in, actually, by and large. Here's another case history. A younger woman. This is a more complicated one, actually. This woman was 59 when she presented, and actually it was back in 2008 when she presented. But you may come across a patient like this. I thought it'd be interesting for the group to look at. So she had back pain in 2008, no precipitating cause. GP did a spine x-ray, showed an L1 fracture. Past medical history, not very much. Mild asthma, never had steroids, well controlled on inhalers. Again, she was tender in the thoracic spine, and she had an x-ray and bloods checked. So there's the x-ray, and as you can see, L1 has gone almost completely. So that's a very severe fracture of L1. The other bloods were pretty unremarkable. She had a pretty severe spinal osteoporosis. Her spine T-score was -4.1. Her total hip was close to the osteoporotic range, and the major fracture, the osteoporotic fracture, was shown there. Not so high as the previous women have shown, but of course this woman was a lot younger. She was 59. And at that time, 2008, we didn't have romosozumab, but she was started in teriparatide. Just showing her progress. This first scan was before she initially presented. She actually was osteoporotic at that time, but for some reason it hadn't been picked up. She hadn't been treated. This is where she presented, 59. She went on to teriparatide. At that point, I don't know if any of you remember, but teriparatide initially was only licensed for 18 months, and it was only in 2009 that the duration of treatment got extended to 24 months. But anyway, she had it for 18 months. She had a pretty good response, 11% increase in spine BMD, 5% in hip, which is unusual in my experience. And we transitioned her to alendronic acid in 2010. And actually, she was pretty stable until 2017. We saw her at the clinic in 2017. We tend to see these patients, actually, continue to see them. I saw her in 2017, no more fractures, height stable, bone density stable. But then, in 2021, she had a sudden deterioration. She had very severe lower back pain. So remember, L1 was already gone, but this time she's got a fracture of L2 and L3. And actually, she had also a fracture of T9, really no specific cause. By the time 2021 came along, it wasn't possible to get a measurement of her spine bone density because of the image artifacts. But we did measure her hip bone density, and here are the T-scores. That's 2010 when she finished the teriparatide. 2017, pretty good, plus 0.6, but 2020, minus 2.6. And I'd be interested in any comments. I've seen this a few times, and you think, well, why is that? She did so well for 5 years, but then has lost bone. And I have to say, I don't have a good explanation for that. I should say that she had some retropulsion of the vertebra, and there was some cauda equina compression. She was seen by the neurosurgeons, but she didn't really have any neurosigns, and actually everything settled down with conservative management. Okay. What did we do? Well, we said, are you sure you've been taking the alendronic acid? And she said, yes, definitely. Had no reason to doubt her. Did discuss the possibility of zoledronic acid, because obviously she'd lost bone, and our usual treatment, or at least one option we give if patients lost bone in an oral drug, is transition to zoledronic acid, thinking they may not be absorbing it. Second option is theoretically she could have had another 6 months teriparatide. Now, you'll be aware that the maximum duration of teriparatide, or recommended at least, is 24 months. She only had 18 months, so she could have had another 6 months, but I didn't think that was really a very good option. And so discussed romosozumab. She opted for it, having heard about it, and she remains on treatment at present. So I'm afraid I don't have any stories about how these patients have responded yet, because we've only just started using it, but these are the type of patients that we're using it in. We're not using it in people just, with wrist fractures or whatever, because I don't think it's indicated then. I think you should be going for alendronate or whatever in those patients. Now, if I can summarize then, just to leave time for questions, I think it's a very good option for severe spinal osteoporosis and vertebral fractures. I think teriparatide is also a good option. So then the question is, well, how do you choose? And I think there's not a kind of definite cutoff, but our rule of thumb is if there's low spine BMD and low hip BMD and a high risk of non-vertebral fracture, that is the romosozumab patient, I would say, because that's where it has really been shown to be superior to alendronate. These are older women, usually, actually, I have to say. Whereas the teriparatide patient, the ones we've seen, and we're still using teriparatide actually, you do quite often see younger women with maybe a T-score of -4 point something at the spine, but actually their hip T-score is like, I don't know, -1.2 or 1.5. They have a lower risk of hip fractures, and that would be perhaps the teriparatide patient. In fact, we do see some patients with severe spinal osteoporosis have been scanned for some reason, who have had no fractures. And again, if you had no fractures and a very low spine BMD, that would be a teriparatide patient. So I'll stop there. I'm just going to have an ad though for my app, the ORB app, Osteoporosis Risk Benefit app, which is available on the App Store and the Google Store, and it's also, there's a website available for you. Quite frequently when you're having a conversation with patients, you want to tell them, or they want to know, well, what is the benefit for me? And the ORB app will do that. And I'm going to click to show you how that may work. I'm going to stop presenting. Well, maybe I'm not going to click. It's going to be too difficult. But anyway, if you Google ORB CGEM, you'll come to it, and you can put in the patient's. I recommend putting in the patient's 5-year fracture risk, because we give treatment in bites of 5 years at a time. But if you put in the 10-year fracture risk, it'll still work. So what the ORB app will do is tell you what is the risk of non-vertebral spine and hip fractures without treatment and with treatment, and what the absolute benefit is. And I can tell you, when you do that and find out what the absolute benefit is, you and the patient will be extremely surprised how modest the benefit can be with some of the treatments. Okay, I'm going to stop there, and I'd be happy to take questions. Thanks.
Perfect, Stuart. That was very good. I think that was very clear, and I'm sure we all enjoyed that. I'm going to start with questions, if that's okay. We've got 5 patients who have started in Grampian and Romosozumab so far. And I wondered what you thought about the cardiovascular risk. Just how careful should we be about people with a history of cardiovascular disease? And if they have no history of cardiovascular disease, should we be going to say to the GP, well, we're going to start this drug, but maybe you should check their cholesterol and make sure their blood pressure is okay? Or should we just accept that that's something that happens in general practice anyway, and just go for it?
Thank you, Alison. I think you have to stick with the SMPC. And if you're familiar with the data, which I'm very familiar with the data, there's actually some doubt in my mind whether there really is an increased risk of cardiovascular events with Romosozumab, because it was seen in one study and not the other. Overall, it was not significant and it's very borderline. But I think if someone's had a previous TIA or stroke or myocardial infarction, I think it's out. Okay, definitely. I would have said if it was hypertension, no, or cholesterol. I mean, obviously GPs are managing that part of the patient's care anyway, but I'd be very happy to use it in a patient such as this. But yeah, if you've had an event, probably if someone had peripheral vascular disease, I wouldn't use it either, just because that's part of the spectrum. But yeah, and if you needed an anabolic, I think that would be a teriparatide patient, Alison, must say.
And my second question, I'm hogging the floor at the moment, is post-therapy. Is it zoledronate you're going to go to if that's a suitable therapy? And would you give 3 infusions or 1, or to lock in the benefit? What's your sort of plan?
Not necessarily. I think our first choice would be alendronic acid, probably. And we published our experience with teriparatide in calcified tissue, like in, it was more than 300 patients, and we used alendronic acid as the first line, and mostly it's fine. The only thing I would say is, you sometimes get a patient, you put in alendronic acid, and then you have to say to them, look, if you're having any problem with it, for God's sake, get in touch, because I have seen patients frequently, you see them 3 years later, and then they say, well, actually, yeah, it upset my stomach and I stopped taking it, and that makes you absolutely mad as hell. But I think if you think the patient is reliable, mostly it's been okay. But I see what you mean, Alison. You think, well, we spent $6,000 or whatever on this treatment, and let's make sure. But yeah, I think it's first choice alendronate probably, and if there's a problem, ZD. Thank you.
So I think Maria Tala has a question.
Hi, I just had a query about how you approach things practically. So we've got people.
I can't hear you, Maria. Can anybody else hear?
I couldn't quite hear that. No.
I'm not sure if my microphone's working.
Oh no, we can
That's
hear you
much
now.
better now.
Okay, yeah, sorry, that was a very good talk, Stuart. I just had a query about how you would approach the patient who's completed perhaps 2 years of teriparatide treatment and come back for their interim scan. There's either perhaps no improvement in bone density or further fractures. Would your practice be to transition to zoledronic acid first, rescan, and then Romo, or would you be comfortable in that situation going direct from teriparatide to Romo?
Yeah, I mean, until we had Roma, I would have said, well, give zoledronic acid or something. One thing I have noticed with bisphosphonates is if you give teriparatide, sometimes the response is disappointing. You actually do often get a kind of quite decent increase with the bisphosphonate, and maybe it's due to mineralization of the bone. But theoretically, it would be possible to give Romo in that patient. Partly because it is has got an anti-resorptive effect, okay, as I showed, maybe not as much as alendronate or the like, but I think it would be. I've not come across a patient like that. I suppose my first inclination is I might see how they went and with a bisphosphonate and then maybe consider it, but there's no reason why you couldn't do Romo. And there are occasional patients, Maria, but they are quite occasional, only maybe less than 5%, where the teriparatide doesn't have an effect, but it's quite a small group. But yeah, I think you could use it.
And I think Eamon's looking to speak.
Yeah, I'm going to be controversial here. With my management hat on, I spend half my life refereeing fights these days between primary and secondary care. And I guess I would be making a case for saying that if we have someone that you think has a cardiovascular history, we can't be assuming that the GPs will always have done their lipids, and that the expectation from the LMCs these days would be that the specialist service would arrange that. I mean, I actually had 2 patients in my clinic at Monklands yesterday who I was considering for Romo. Naturally enough, being Lanarkshire, one had had a previous heart attack and one had a TIA. So I sat and did the assigned scores. First thing I've done an assigned score in a hospital clinic for someone for an osteoporosis treatment. But I think our colleagues in primary care would be expecting that the secondary care service would do the cardiovascular assessment. Something you might be able to find on the vision summary within Portal, but it's not easy to find. I've certainly found it difficult yesterday.
Oh, thanks, Simon. I mean, basically, if someone had either of those histories, I wouldn't be even considering Romo. So they would be out of the park.
I mean, the one that was a query MI was from 20 years ago when she was originally diagnosed. Hospital at home had said possible previous MI, and ultimately I did a sign score and I kind of crapped out of it basically at the end of it and decided not to bother.
I mean, I must admit, we're certainly not in it. Well, first of all, there's nothing in the SMPC to say, you should give, I don't know, statins or whatever, like unlike, for example, an IL-6 inhibitor, which is, so it's not altering that, and it's not, as to my knowledge, have an effect in cholesterol, and no osteoporosis clinic I am aware of is equipped or staffed to start monitoring blood pressure and monitoring cholesterol. So I think, I mean, if someone has that, I mean, sometimes we see patients and their blood pressure is high when they come up to clinic, and then you check it again at the end, it's still high. You do say, well, sometimes I'll do my letter to say, actually, we just noticed this patient blood pressure was high. We draw that attention to the GP. I mean, that's how I would handle it and wait for the flag, Eamon.
Yeah. As you know, I try to see it from both sides and referee the fights. I think, one of the things we're working on is trying to get direct transfer of a lot of the vision information with referrals automatically. Because if you've got 20 years worth of BP results there, or A1Cs or whatever it is, then we just need to make sure that that information does flow, as smoothly as possible to allow you to make good decisions.
I must say, in Lothian, I don't know how it is in other health boards, but in Lothian, we can see all the GP results, like if there's cholesterol or whatever, HbA1c. And also when the Sky referrals come through, there's often a pretty good potted summary of the patient's history. Like, that's based on we can't view the GP records, but when the Sky referral comes in, it's actually usually for DEXA. There's stuff about previous fracture, MI, all that kind of jazz. And of course, you also have the whole electronic record from other encounters, say with, I don't know, cardiology or whatever. So I think we're in quite good shape. I mean, certainly better than ever before. Remember the days when you were having to order notes from St John's Hospital. I mean, it would have been impossible then. But I think we're in quite good shape at the moment, all things considered.
I think Dr. Chung has a question.
Hi, thanks for that. Sorry, I was quite late to the talk because of another MDT, but I don't know if you have any experience using Romosozumab in someone with a previous malignancy. The particular case that I had was a lady who is still being treated for breast cancer.
Okay, thanks. I don't think there would be a contraindication, actually. And in fact, I've treated a couple of patients who had, this is quite a common occurrence, women, previous history of breast cancer, radiotherapy, low spine BMD, but teriparatide is contraindicated, okay? And to my knowledge, there is no contraindication to Romosozumab. There's no signal for cancer. So I think it would be, that would be a valid choice. And in fact, Rosemary Hollick's on the call and we were talking about would you use it in MGUS? And I think, Rosemary, you are using it in MGUS, and I certainly would actually. So yeah, don't think it's a problem.
I don't know if Rosemary wants to comment.
Hi. Yeah, so I did discuss it with our hematologist who discussed it with another world-renowned expert in myeloma, and I believe that there is some evidence in mouse models of myeloma that Romosozumab reduced tumour burden, and so their expectation was that Romosozumab might actually be helpful in terms of the MGUS and in terms of reducing that. So we are going ahead with it. We are monitoring serum free light chains and serum immunoglobulins and electrophoresis baseline 3 monthly. But the patient's fully informed, but they were very comfortable with going ahead with it.
Yeah,
so we'll see what happens.
Yeah, thanks. No, I think that's right. And in fact, there's evidence that part of the osteoporosis you get in myeloma and MGUS is due to Dickoff. It's an inhibitor of that pathway, actually. So there's a good pathophysiological basis to try it. That's for sure.
So we've had a question in the chat, and could Romo be used as an insufficiency fracture secondary to radiotherapy, Stuart?
Good grief. I'm not, well, you could do it. It would be entirely off-label, and you'd have to have a PAX2 submission, and then you'd have to have some supporting evidence that was going to be effective, which you may find difficult. So, I mean, it may work. I mean, there's been a lot of stuff about anabolics and insufficiency fractures. Teriparatide was one, but things like pelvic fractures. I'm not sure there's been any proper trial of it, actually. So whether it works or not, I seem to recall a trial with teriparatide looking at, and I don't know if it was pelvic fractures, but it didn't show a difference as I remember, but I could be making that up. So I wouldn't advise it basically necessarily. Yeah.
I suppose it's quite a common clinical scenario that we see people being referred with fractures due to in a radiotherapy field, and usually when you scan it, I base it on what their bone density is. If they actually also have coexisting osteoporosis, I might go ahead with therapy. And if you don't, I say this was just bad luck and there's not much we can do at the moment about it other than making them calcium vitamin D replete.
Yeah, I think that's right. I mean, obviously radiation does a lot of direct damage to all of the bone cells, and it's an area that would be interesting for some kind of trial to see if it made any difference. I mean, there was a lot of hoo-ha about giving bisphosphonates for avascular necrosis of the hip, but there's not any evidence that it works. So it's one of those things where there is empirical treatment going on, but you don't know if it works, and I'm not a fan of that personally. In fact, I'm very much against doing it because I don't think it takes you any further.
Shauna, your hand's up.
Oh, she's frozen.
Hello,
back.
Can you hear me now?
Yeah,
yes, we can.
Yeah, so I've got a question that Dave Rigby asked me to ask, and it's for those of us that are out in the sticks and whose services are and it was whether you would see Romo as something that could be instigated in primary care or whether it should be coming from a secondary care setting at the moment.
I think there's nothing to stop you starting it in primary care. I mean, just the way services are set up, certainly in the likes of Edinburgh or cities. I mean, GPs have got a million things to do, and this is quite a kind of specialised thing, as I see Eamon Brankin laughing there. So it's quite technical, I suppose it's quite technical. You got to know a bit about it. You got to know the contraindications. You probably want a DEXA. You probably then want another DEXA. I think it would be challenging, but not challenging. But I think you would want someone to know what they're doing, okay? And if someone was happy, they were comfortable with it, there is no reason why not, okay? But like many people, you might be more comfortable handing it over. I mean, like if we get someone with diabetes and high dose steroids, I kind of call the diabetic doctors, because I've got plenty to do of my own. So.
Okay, thank you.
Okay, cheers.
So are there any more questions? Because I think we've kept Stuart very busy with our questions, and I think it's a good range of questions we've had for him as well. So if we're all finished, I really just want to say thank you very much, Stuart. That was great. We'll let you get on with your weekend plans.
Thank you.